Okay, we should start now. Good afternoon, everyone. Welcome to our weekly webinar organized by the Community College of Physicians Malaysia. And the theme of the month is nephrology. With us here today is our chairperson, Dr. Teng Kok Seng. He obtained his MRCP in 2011 and completed his subspecialty in nephrology training in 2017. He has published numerous papers in the field of nephrology. And currently, he's a consultant nephrologist in Hospital Taiping. Without further ado, let us welcome Dr. Teng.
Okay, hello. Can you hear me, Kelvin?
Yeah, I hear you.
Okay, thanks, Dr. Kelvin, for a kind introduction. So, hi, good afternoon, everyone. Thanks for joining us for today's webinar with the topic of renal transplantation, a brief overview. So, we are honored to have Dr. Dewa Mara as our speaker for today. Dr. Dewa Mara is a nephrologist from Hospital Selayang. She graduated from Melbourne University in 2010 and passed her MRCP in 2016. She furthered her subspecialty training in nephrology and completed in 2020. She has special interest on renal transplantation. For information, there's only 2 MOA hospitals that are doing renal transplant. Hospital Selayang is one of them. Therefore, Dr. Dewa is the right person to talk to us on this topic. I know it's not easy to talk about renal transplantation within 45 minutes, but I'm sure that Dr. Dewa will keep to the time and yet still able to highlight to us the important topics, important points for this topic. I do hope we'll have 10 to 15 minutes for Q&A later. So without further ado, let us welcome Dr. Dewa Mara.
Thank you very much, Dr. Teng. Thank you, Kelvin, for the kind introduction. It's an honor to be invited to speak in this webinar, especially a topic which is very dear to my heart and something I'm really passionate about. So my topic today is about kidney transplantation, a brief overview. I'll try to keep to my time. I just got 50 slides. Just a minute, it's kind of jam. Okay, so my outline today would be the basics of kidney transplantation, the benefits of kidney transplantation, immunosuppressive medications, and common post-transplant complications. I've kept it brief. There's really not enough time to speak about each topic, even if it's 1 or 2 hours, you can speak for the whole day. So I've just tried to keep it basic so that all of us can understand. And please do ask questions if you're not clear about it at the end of the session. So the basics of kidney transplantation. So what is kidney transplantation? It's a surgery to place a kidney from a donor. And this donor is someone who could be living or who has passed or succumbed. So the person who receives the kidney is called a recipient. So this donor can be a living or a deceased person. And kidney transplant by far is the most effective therapy for end-stage kidney disease and is proven to be the best modality of kidney replacement therapy. So if you look at kidney transplantation, I think one has to cover the history of how it all started. So it definitely started in an experimental way where they started using kidney transplantation in animal models. They used dogs, they used mice, and subsequently in 1954 was when everything was successful. So Joseph Murray performed the first successful kidney transplant in Boston. It was in Birmingham Hospital in 1954, and it was in twins. So a brother called Hendrik donated it to his other brother who was suffering from glomerulonephritis at that point, and he wasn't doing well. So since it was an identical twin, they did not give any immunosuppressant since there should be matching in terms of human leukocyte antigens and there shouldn't be much antibodies. This transplant was really successful. In fact, the recipient continued to live for 9 more years and succumbed not from his failed graft, but succumbed from a myocardial infarction. So his graft was still functioning 9 years later. And bear in mind, this was when there was no immunosuppressants established at that point of time. Subsequently, in 1964, this was when immunology was coming up, and Tarasaki and Patel in 1964 came up with the cytotoxic cells, which in immunology pre-transplant, the test which we are using at this moment, complement-dependent cytotoxicity, was based on Paul Tarasaki and Patel. And then moving on, all the immunosuppressants came about. So initially there was no immunosuppressant. Then we started on with corticosteroids. There was radiation, which was going on at that point to kill your cells to prevent rejection. And at that point of time, in prior to 1950, 1960, when calcineurin inhibitors like cyclosporine and tacrolimus was brought in, there was a lot of rejection. Graft failure in the first year was really high, 50 to 60%. But after 1960, when cyclosporine was added to prednisolone, the rates of rejection in the first year post-transplantation improved drastically till at this point we are got a graft success rate of 95 to 98% in the first year in living related and close to 90% in diseased kidney transplantation. So the key is immunology, key is identification of low risk, high risk patients, providing the optimum immunosuppressant and getting a donor. So subsequently, when all this happened and we knew that we could transplant patients, there was a shortage in organ donation. So then we accepted, disease donors. So we accepted those who had brain death, those who had circulatory death, expanded criteria donors. So what does expanded criteria donors mean? It means someone who's more than 60 years old or 50 to 55 with hypertension, a creatinine of 130 and has a stroke. So these are extended criteria donors whom we have accepted. And then we had to improve on how we procured the organ. So we had to come up with solutions. The solutions which we use at this point is an HTK solution to preserve your kidney. And at points that at certain places use machines to perfuse the kidney. So all this came up to preserve the kidney to get better outcome. So all this helped to prolong graft function to what we know now. So this is the Murray, this is the Hendrick brothers who went through the first successful kidney transplantation, and that is the OT in a Birmingham hospital. And this was published in NEJM in 2004. And the surgeon who performed the surgery, Joseph Murray, won the Nobel Prize at that point for successfully transplanting these twins. So now we move on to Malaysia, because we have to know what's happening in our country. So the first kidney transplantation was performed in Hospital Kuala Lumpur in December 1975. This kidney was from a donor who was a brother who gave it to his other brother, and the recipient lived for 30 more years post-kidney transplantation. Subsequently, this was followed with a disease donor transplantation in 1976, and we performed our first ABO incompatible transplant in July 2011 in Prince Court Medical Center. Of course, this is a private center, and subsequently, Hospital Kuala Lumpur and Hospital Selayang started performing ABOI transplantations. Selayang performed the first hepatitis C disease donor kidney transplantation in 2021, and UMNC performed the first RVD recipient transplant in 2022, last year. So the wife gave the kidney to her husband, actually. So as Dr. Tang mentioned, in the government setting, 2 hospitals performed kidney transplantation, Hospital Kuala Lumpur, which pioneered it, and followed by Hospital Selayang. So Hospital Kuala Lumpur performs about 100 kidney transplants per year. They have 3 living transplants a week, and they attend to cadaveric or disease donor transplantations as well. In Selayang, we perform 1 living related transplant every week and cater to disease donor transplantation. So in our hospital, it has been about 40 transplantations per year, except for this year, we have achieved a landmark of 68 transplantation. So this is the first that we have surpassed 50 transplant this year. So we are really excited about this. And the other settings which perform kidney transplantations are UMMC, UITM, and in private, Prince Court Medical Center, Sunway Medical Center, and Makota Medical Center in Malacca. So I think all of you would like to know how the transplantation is performed and where the kidney is actually placed. So this is just a simple cartoon illustrating where the graft or the transplanted kidney would be positioned. So traditionally, the artery of the donor is anastomosed to the external iliac artery and the vein to the external iliac vein, and the ureters directly implanted to the bladder. There is no anti-reflux operation performed, which is why in a graft kidney, you're expected to have some mild hydronephrosis when you scan a graft kidney compared to your native kidney, which is not supposed to have any hydronephrosis. So how about the surgical techniques? There are multiple ways to perform this surgery. There are open techniques. Open surgery is not common nowadays. Everyone has moved to laparoscopic surgery. So in Selayang, it depends on which kidney we are procuring. So if we are procuring the left kidney, we usually use the laparoscopic hand technique. But if we're procuring the right kidney, then we go in an open manner. And there's also robotic means to perform this surgery, but it's not done in Selayang. They do have it in Hospital Kuala Lumpur. So just to go back on the basis of kidney failure and how we overcome this problem. So in terms of kidney replacement therapy, there are 3 modalities to overcome this problem. The first one is hemodialysis. I'm pretty sure everyone is aware of how this works. Number 2, you have peritoneal dialysis. And the third one would be kidney transplantation. So just to give you a rough idea, in Malaysia, this is the latest statistics up to 2022 in the National Renal Registry. You can see that there's a rise of new dialysis patients from 6,000 or 7,000 10 years ago to something approximating 10,000 now. And this is a really large number, which means every year you're expecting 10,000 patients to be on dialysis, either peritoneal or hemodialysis. And if you look at the breakdown of patients being on hemodialysis, you see that there's a huge number of patients who are on hemodialysis. You see a lot of hemodialysis centers at this point of time. Compared to hemodialysis, only about 1 out of 9 would be on peritoneal dialysis. And it's so sad that when you look at transplant patients, it's so scarce and so few. Imagine only 200 patients going on kidney transplant when you have 10,000 patients who actually require this therapy. So to show you in a better perspective, a graph would be better to illustrate this. So if you look at the 3 colors here on the number of patients being on different renal replacement modalities, if you look at the graph, the chart in blue, so that is the proportion of patients who are on hemodialysis. In red on peritoneal dialysis, and green, which you can barely make out, are the patients who are transplanted every year. So this is beautifully captured to give you a rough idea of the total number of patients on dialysis. So as out of 2022, we have about 51,000 patients on dialysis. And if you look at the total number of patients who have been transplanted so far in 2022, there's just 212. So there are only 4 patients who are transplanted for every 1,000 patients who are on dialysis. So this is a very small number. And because the number of patients on dialysis has increased, this transplantation rate per 1,000 dialysis patients is really small compared to what it was before, just because the number of patients on dialysis has increased so much. So this illustrates the kidney transplantation per 1,000 dialysis patients. So if you look at 2022, you can barely see the number. That's because it's 4 per 1,000 dialysis patients. So that's really, really low. This is what I'd like to highlight, that transplantation is really low in Malaysia. So let's compare it to the world. Where do we stand? We stand at the last part there. That's where we stand. In fact, I think Bhutan is below us. Okay, so that's how few kidney transplantations are being performed in Malaysia. If you look at Norway, if you look at Netherlands, UK, Spain, that is the number of transplants they perform per 1,000 dialysis patients. So if you look at the waiting time for a patient in Malaysia, it's definitely more than 10 years on dialysis if you're waiting for a deceased donor kidney transplant. My oldest patient on dialysis was on dialysis for 20 years. He was on dialysis for 20 years, and that's when he had his kidney transplant. This is different. This is different compared to Norway, compared to US, UK, Australia, where the waiting period is only 3 to 4 years, and they are relisted when their transplant fails. This is not going to happen in Malaysia because the organs are so scarce that we can't afford to give it to the patient who has undergone kidney transplant and has failed. So this is the reality which I'd like to show you. So this is the worldwide kidney transplant from deceased donors. So if you can have a look, Malaysia is below there, right above Jordan. So, I'm trying to show that we are really low when it comes to deceased donor transplantation. This is because the awareness isn't there. So if you can imagine in a year, 10,000 patients are requiring dialysis, either hemodialysis or peritoneal dialysis. Only 40 donors donate their kidneys per year. So you can imagine how many are waiting on the wait list, to be transplanted. So based on the history, based on what I've mentioned about, how they have progressed so far in medications and all those things to prolong graft survival, there are 4 key factors which I think is important for a successful kidney transplantation. You can't perform a kidney transplant without donors. So we need donors. So they could be living. So most of the time it's related, either spousal. We call spousal donors emotionally related donors. And other related donors are your siblings, your parents, your first degree relatives. And of course, there are unrelated donors. In Malaysia, we so far have very few altruistic donors, and this has to go through the ethics committee to get an approval before they can be transplanted. So in terms of disease donors, there are a few types of disease donors, actually. There are donors who donate after a circulatory death. There are donors who donate after a brain death. And there's the expanded criteria donors, which I mentioned earlier. So the expanded criteria donors normally have a marginal kidney. And what I mean by a marginal kidney is the kidney function or the GFR might not be that great. And unfortunately, since we do not have a list to match marginal kidneys and marginal recipients, the list which is created in our country goes on a first come, first serve basis based on the list and dialysis vintage. So, a marginal donor might give the kidney to a recipient who might be fit. It's just because the organs are really scarce and we can't follow marginal donors, marginal recipients criteria as what's done in US and elsewhere. Of course, what else is important is the knowledge of immunology. You need to know your immunology because you want to give the best immunosuppressant. You want to give the best medication to prevent rejection, because when there's a rejection, the graft outcome isn't great compared to when there is no rejection. So expanding the knowledge, research and studies on immunology is key for a successful graft outcome. So you need to know the effectiveness and which immunosuppression is effective for which particular transplant recipient. So that would be based on a few criteria, and that would enable us to provide precision medicine, which is key here. And of course, immunosuppression comes with infection, and having a graft comes with the risk of a rejection. So you should be able to identify and treat rejections and infections. So I'll move on to the recipient selection. Actually, this is a whole topic on its own. I'm just trying to cram everything about transplant, so it's really brief. So when you come to a recipient, someone who's on dialysis, who requires a transplant, you can do it before the patient needs dialysis. For example, if the GFR is about 15, it's about 10, and they do not want to be commenced on dialysis yet because they don't need to have be on dialysis yet. They have good urine, they are functioning fine, and they have a donor who wants to donate. So we can perform a preemptive kidney transplant, and studies have shown that preemptive kidney transplant has a better mortality benefit compared to those who have already initiated dialysis. So there are really very few contraindications, actually. We do a lot of patients with medical comorbidities, but of course, this is really center-based, and different centers accept different recipient profiles and re-stratify them in a different way. So it's very important to go through the primary etiology of kidney failure, because by knowing the primary etiology of kidney failure, you are able to anticipate the recurrence of the disease post-kidney transplant. There are certain diseases of which they recur, for example, glomerulonephritis. FSGS, for example, focal segmental glomerulosclerosis, recurs immediately post-transplant. So if you know the patient has this as the primary etiology of kidney failure, you would look hard for it and you would treat the patient and not miss it. So that's why it's really important to ascertain the etiology of kidney failure. Unfortunately, in Malaysia, it's really difficult because most of them come with shrunken kidneys or come end stage, and we do not have a kidney biopsy to get a proper diagnosis of why their kidney failed. And we presume it's missed glomerulonephritis and so forth. We need to have a cardiovascular screening because these patients have a high cardiovascular risk, especially those who have been on dialysis for a very long time, waiting to receive a kidney on the disease donor program. So they require cardiovascular screening. Immunological screening is very important. We perform cross matches. We look at their bloods to see if there's any antibody. And this is why I'd like to highlight that blood transfusion is something which confers a high immunological risk to a recipient. This is because the more blood you transfuse, the more antibodies are formed in the body. And this provides a very difficult situation because sometimes these antibodies over time would not be detected in your blood test. And once you have transplanted the kidney, boom, the antibodies resurface, and now you are at a risk of rejection. So if possible, we have to really, really transfuse only when indicated. This is especially true for end-stage patients who have who are very prone to be anemic for various reasons. So transfusion in this category or group of patients should be taken seriously. So pregnancy offers a immunological risk, and previous organ transplantation makes you sensitized, and hence you are a patient of a high risk when you're being transplanted. We perform a lot of imagings for our recipients. We perform an ultrasound to make sure we're not missing something there. We perform pelvic Doppler ultrasounds to make sure that the vessels are okay for anastomosis during the surgery. And we get a CTU done to make sure that we are not missing some stones, we are not missing something which is potentially reversible. We perform infective screening. It's really important to make sure that the hepatitis B antibodies are adequate because you're going to immunosuppress them. We need to know certain viral status for the recipients because post-transplantation, we would need to plan to give them certain antivirals, and we need to monitor them. So cytomegalovirus, Epstein-Barr virus, this is something we really look out for, and we would actually re-stratify them based on their viral status. So we would also do appropriate age-related cancer screening. This is not universal. It depends on your country. It depends on the prevalence of cancer of a particular organ in that country. So we would screen them based on the country's recommendation as per normal population. There's dental evaluation and, importantly, psychological evaluation, because this is actually a major surgery. It's a life-changing event, and life is not going to be easy in the first 3 months, at least post-transplantation. They would be in and out of the hospital. Some stay in for long periods of time because of certain complications. So many go into a state of depression at times, because what they expect post-transplantation is immediate recovery, go back to what they were, before this. And it doesn't happen that way to everyone. So a psychological evaluation is really important to explain to them what to expect, what to anticipate. So that's really important. So now I'll actually go to the donor selection. This is more for the living aspect, but there's also some which I would mention about the disease donor. So as mentioned, we have related, emotional related and unrelated donors. And what we would do, we would establish the blood group. I mentioned that we started off with compatible blood group transplantations. So in Selayang, we started our first ABO incompatible transplant in 2020. It's very recent. So it's because compared to a blood compatible transplant, a blood incompatible transplant is definitely higher in terms of risk, in terms of cost. You'd have to perform a few sessions of plasmapheresis. They require higher immunosuppressions. So yes, in terms of medical comorbidities, actually, this is up to debate. There is no fixed rule in terms of certain medical comorbidities. Some would take hypertensive patients. Of course, you have to make sure that you do not have target organ damage, but some would take patients with a good BP control, even if they're on 2 antihypertensives. Some would limit it to 1. Some would do diabetics. In Malaysia, we do not do diabetic donors. I'm talking about living related. We do not do diabetic donors, but I think we can move to doing older, well-controlled diabetic donors who do not have target organ damage. This is something we can look into, especially since we lack donors. We don't do donors with ischemic heart disease, and we do not do donors with renal calculi with a positive metabolic panel. What this means are the donors are stone formers. So we do not want to take a kidney, leave behind a kidney, and the donor develops a renal calculi, which then renders him or her end stage or CKD in the future. Obesity is something which is debatable. Different centers do different BMI patients. So in Selayang, we try not to do patients who are more than 30. We have done, a BMI of 31. But of course, the surgical complications are higher in donor patients. And we do know that obese donors have a higher risk of CKD. So, we try to get them to lose as much weight as possible pre-transplantation. And of course, patients with a poor calculated creatinine clearance or glomerular filtration rate wouldn't be suitable to donate. Patients with malignancies, active infections, those who are still actively smoking or, are drug chasers, we don't do them as well. So what we do is we establish the immunological risk besides blood group compatibility. I mentioned earlier that we do cross-match tests. This cross-match test is a talk on its own for another 1 hour or 2 hours. But just to simplify, we take the blood from the donor, we take the blood from the recipient, we will see if there is a reaction where the cells are lysing and the cells are dying. If the cells are dying, we wouldn't do them because this is something which is going to cause hyperacute or acute rejection and end up in graft failure. And this is really center specific. Different centers do different targets of antibodies. So in Selayang, we have not done anyone who have donor-specific antibodies, but we just did one this year. So we are hoping to do more. So different centers really practice different levels. So we have imaging, so we do an ultrasound abdomen, we look at the kidney size. We do a CT angiogram to make sure the vessels are good so that we can plan which side of the kidney we're going to take, what anticipated complications to look for. We'd have cardiac evaluation for the donor, depending on the age, depending on the risk factors, cancer screening, and psychological assessment. So the donor and recipient would be assessed if they're psychologically suitable for this procedure. So I think when one talks about donating, one would want to know what's the risks to himself, or the recipient would want to know what's the risk to his loved ones who's going to donate. So when it comes to death, all sorts of causes of death, the risk is really less than 0.1% actually. So most of the time they come in, for wound infection or wound breakdown, and that's also very rare actually. In Selayang, in donors, I've only seen 1 or 2 wound infections so far, and they are all good and discharge, day 3, and they do really well after transplant, after donation with no issues. So that is in terms of, operative mortality, etc. But what is the risk of progression to end-stage kidney disease? I think this is something which they would want to know. So compared to a healthy donor, a donor who has no diabetes, no hypertension, who's healthy and who's going to donate, and comparing this to the standard healthy population with no comorbidities, there's definitely a higher risk for donors to develop end stage. Okay, at 15 years, there are about 10 times more higher to develop end stage compared to the general healthy population. But this risk, if you convert it in terms of percentage, is actually less than 0.1%. It's just 0.06%, which means out of 1,000 patients who donate, 994 would not develop end-stage kidney disease. So this is how I explain it to patients during counseling, transplant counseling. I'll draw this graph and I would tell them, look, yes, compared to the average population, you're at a higher risk, but the risk is actually low. So that is a general risk. You'd want to break it down to who has a higher risk to develop end stage. So the males have a 1.75, so 70% higher risk of getting end stage. Those with a higher BMI have a higher risk of getting end stage. Lower EGFR, I think that's self-explanatory. If you start off with a poorer kidney function and you have donated one, you're left with very minimal kidney function, and that kidney has to compensate. So it's expected that they would have a higher risk of developing end-stage kidney. In terms of relationship with the recipient, if you're a twin, you would have a higher risk of developing the disease because most likely you might share certain reason to develop end stage as the recipient who actually had end stage. Do you understand what I mean? And those with a lower socioeconomic status have a higher risk of developing end stage. And this is especially true in the African American population, where they are at a higher risk to develop this at a younger age. So then we would come to which donor is better. Would a diseased donor offer the same graft outcome compared to a living donor? So we know that the outcome is better in a living donor. There are so many reasons why it is so. If you look at it, we have all the time to match the donor and the recipient. We have all the time to control it in a good environment for the surgery to perform. We have the time to ascertain the risk, look at the immunological risk profile, look at the antibodies, and and plan the surgery well. And when the kidney is harvested, it's implanted in a short period of time. You can make do with a surgery in about 2 hours compared to a diseased donor transplant, where the kidney would have to be transported probably from Sabah, from Sarawak, from Johor, probably to KL. So it takes some time. My longest disease donor transplants cold ischemic time was actually close to a day, 23 hours. The kidney is a very beautiful and forgiving organ. No organ would tolerate such a long cold ischemic time. Kidneys can go up to 24 hours. The heart only tolerates 4 hours, the lung 6 hours, and the liver also 6 hours, but the kidney can go up to 24 hours. So it's an organ which tolerates a lot. So in general, when someone asks me how long can my transplanted kidney last? So if it's from a living donor, I would say it's about 12 to 15 years. Some go up to 30, 20 years. I've even got one who is actually 30 years into kidney transplantation. And when it comes to deceased donor, they would probably last for about, 12 years, 10 years. But it's very difficult as different patients have different immunological risk. And, this is just a general estimate. So in terms of live donors, they get transplanted really soon, probably 1 or 2 years into dialysis, they get transplanted. So their waiting period is shorter. So there's less complexities. Your bladder is not that small. Your bladder is, something which can still tolerate the surgery. As opposed to someone who has been on dialysis for a decade, for 2 decades, your bladder is shrunken. And when it expands, there can be a lot of complications when you anastomose the ureter to the bladder. There could be leakage, etc. So it's only logical that living transplant would do better. And there are a lot of cardiovascular issues, which you expect in a diseased donor kidney transplantation just because of the dialysis vintage, which is so long. And this just makes it even tougher. So this is just a simplified graph to demonstrate the overall graft survival in live versus diseased donor transplantation. If you look at the graph on the left, it's just a combined overall graft survival, which means it takes into account live and diseased donor transplants. And if you look at the first year, the outcome is amazing. It's 97 to 98% of the grafts last without any issues. And when you look at 5 years, it's about 93%, and 15 years, 76%. This is a really good figure with the development of immunosuppressants. So when you then divide it into live and diseased donors, you can see that the graph starts to separate that. In a live donor, it's about 98%, but in a diseased donor, it's about 95%. So there is a separation. It's not that statistically significant, but as time goes by, the separation becomes larger, okay? So that's just the brief basics of kidney transplantation. Now I'll go into the benefits of kidney transplantation. So many studies have shown survival benefit compared to those being on dialysis. The mortality of those being on hemodialysis or peritoneal dialysis is about 10% a year. So this is a really large percentage of patients who would actually, pass on. So this is overcome with kidney transplantation. So when I counsel the patients, I would tell them it's not a bed of roses for the first 3 months. The first month is tough. The mortality is higher than those on hemodialysis or peritoneal dialysis in the first 3 months, just because you're, prone to infection, you're prone to many things at that point of time. But after the 3rd month, the graph separates and the survival is definitely better for those who are transplanted compared to those remaining on dialysis. So this is how I motivate them, to do transplantation. And even those who get a marginal kidney, what I mean by marginal kidney are donors who are old, more than 60 years old, 70 years old. Last 2 weeks ago, we transplanted a donor who was 82 years old. So, their kidney function isn't that great. Their GFR might just be, 60, 70 and 80, 60 or 70. So it's not something which is really great. And even these patients who receive these marginal kidneys do better than those remaining on dialysis. So, this clearly shows the benefit of transplantation. There's cardiovascular benefits because we know many studies have shown that when your eGFR is more than 45, the cardiovascular mortality actually improves. So that's why when you're transplanted, your eGFR is more than 45, you have a survival benefit. And actually putting all the medical aspect aside, just the quality of life. You don't have to go for dialysis 3 times a week, 4 hours each session. You end up being so lethargic. You can't do what you want. You're stuck there. Peritoneal dialysis, you have to do your exchanges 4 times a day. Even if you're on an ambulatory peritoneal dialysis, you have to spend 8 to 8 hours or 10 hours hooked on the machine at night, there is this restriction, of what you can actually do out there. So once you're transplanted, you're back to normal. You're back to normal. You take your medications, you can do what you want, so there's definitely a better quality of life. People are happier, and it's definitely cost effective in the long run. The average amount which we spend for kidney transplantation probably is about 300,000. This includes your medications, treatment, surgery. But after that, the cost is cheaper than being on hemodialysis or peritoneal dialysis in the long run. So I'll move on to immunosuppressive medications. I'll try to be faster. Immunosuppressive medications. So if you look at the timeline, we started with nothing, which then added on prednisolone, there was radiation, and then came calcineurin inhibitors. What we know now would be cyclosporin and tacrolimus. And then came the antimetabolites, your azathioprine, which was then mycophenolate mofetil. And then you have other new agents which are, which came up, such as belatacept, etc., everolimus, and all these things. I wouldn't go into detail, but this is just a timeline to show you how much immunosuppressive medications have actually gone and expanded. So there is no nephrology trainee who wouldn't know this image. It's in any jam, and in every immunology class, this would be put up. So just to summarize this cartoon, there's a kidney there, it's foreign to your body, the T cells would be activated, stimulates your B cells, produces antibody, and then you get rejection. So how all this happens is through these three important signals. You have signal 1, signal 2, signal 3. All these signals have to work for this to happen. So if signal 1 works, signal 2 doesn't work, you won't get the rejection or the antibodies produced. So all three has to work, and this is how your immunosuppressants come to play. So what I've actually circled in red are the immunosuppressants available in Malaysia, which we use. So the three most common immunosuppressants which we use post-transplant would be a calcineurin inhibitor, mostly tacrolimus after Elite Symphony study, the landmark study, which showed that tacrolimus is superior to cyclosporin. So all my transplant patients would be on tacrolimus, mycophenolate mofetil, and prednisolone. This is the three medications which they would be on. Then there would be some patients who wouldn't be able to tolerate certain medication, and then we would swap them probably to everolimus, which is your mammalian target of rapamycin inhibitor. And some might not be able to tolerate mycophenolate mofetil, or some might want to be pregnant when there's a stable graft, then we would swap them to azathioprine. So this is just a brief overview to show you what is available in Malaysia. And the one circled above, the CD25, is an induction agent. And the one which would act on your signal 1 is also your immunoglobulin, thymoglobulin, which I'll briefly mention. So the medications I mentioned earlier would be induction. What's an induction agent? Is to suppress your T cells. So when you give an induction agent, you suppress your T cells for a short period of time, so they don't get activated, okay? And then this won't trigger reaction. So then there are maintenance immunosuppressants, which means you induce them and then you maintain them with this medication lifelong. And then, of course, there's treatment of rejection. So how do we decide on the medications for induction? So as I mentioned earlier, immunology is the key. So we would risk stratify our recipients based on their immunological risk, whether they are of low risk or they are of high risk. If they have low risk, some would not even give induction. For example, twins, identical twins, they wouldn't need induction agents, or siblings with a full match might not need induction. So far in Selayang, we do not practice no induction technique. We induce the lowest with basilizumab. And those of a higher risk, such as those who have antibodies, pre-existing antibodies, who have got, a very surgically challenging case, which took a long time and you anticipate a lot of injury, we might give them thymoglobulin, which is a more potent T cell receptor blockage. So then your maintenance therapy would be your calcineurin inhibitors. I think you're all familiar with cyclosporine, tacrolimus, because these medications are used in many glomerulonephritis disease such as lupus. Then we have our antimetabolites, mecophenolate, and also azathioprine. Azathioprine has run out of favor, but we still do use them in certain cases, especially those who are, wanting to get pregnant and those who can't tolerate mycophenolate. And then there's your mTOR inhibitor, everolimus. We do not use sirolimus here, but other countries do use sirolimus. Sirolimus was originally used in cancer, and then it was used in transplant, and it has a very long half-life, sirolimus, 2 weeks to achieve its steady state, compared to everolimus, which is really short. So we use everolimus, and the other medications such as belatacept is not available in Malaysia, and of course we use prednisolone. Prednisolone blocks signal 1, 2, and 3. So treatment for rejection would be your methylprednisolone. We would give that for anyone with any form of rejection, and your T-cell depleting agent and anti-thymoglobulin. And depending on what type of rejection, whether it's cellular or antibody mediated, the first two, which is in light blue, is commonly used for cellular rejection, and the rest below for antibody mediated rejection. We do not use eculizumab because we do not have it in Malaysia, and we do not have imlifidase. Some centers out of Malaysia use tocilizumab. We do have tocilizumab actually because we used it during the COVID area. We have not used bortezomib, and we have not done splenectomy. So when you have antibody-mediated rejection, we would give methylprednisolone, we would do plasma exchange, and we would give IVIG. And when it's refractory, we would give rituximab. So you would need to know which drug interacts with our immunosuppressions, because sometimes these patients might come and see you, and they might come with pneumonia, and you might want to prescribe some medications. So it's really important to know which drug interacts with our immunosuppressants. So if you're going to prescribe them macrolides, this would really increase the tacrolimus level or the everolimus level. It would really be high. So you have to cut down the dose of your CNI or mTOR inhibitors. Antifungals do this as well too. We use calcium channel blockers such as diltiazem to increase the level of CNIs because this could help us with our cost as well. So other medications which rapidly decreases your level of CNI would be your anti-TB medications, especially rifampicin. So if you're going to give a patient a TB medication, the patient is on tacrolimus, you'd have to preemptively increase the dosage of tacrolimus. And these are the common side effects because when it comes to calcineurin inhibitors, it works on the hemodynamic pathway. So you'd have patients with hypertension and you'd have patients with diabetes. This is especially true in the tacrolimus group. They have more diabetes than the cyclosporine group, but those on cyclosporine tend to have more gingivitis and hypertrichosis. Those on MMF, MMF is quite a bad myelosuppressive agent, especially if your creatinine isn't so great. And it's very common to have gastrointestinal side effects. And because it's an antimetabolite, it kind of blocks your T cells, which are there to kill all your viruses. So you're prone to, have all these viremias with high doses of MMF. Sirolimus or high-dose everolimus can cause proteinuria. So in CONVERT study, it wasn't something which was encouraged. Let's say if a protein of more than 800 milligrams to a gram, we wouldn't initiate the patient on everolimus because it worsened the proteinuria. We would also not initiate them on sirolimus or everolimus if your GFR is less than 40 because it's shown to progressively worsen your GFR if you initiate them on that. It has also problems with wound healing. So in the Elite Symphony study, those who were on sirolimus had more wound breakdown, had more lymphocyles, and higher levels can cause pneumonitis and oral ulcers. We see it's very common. We see a lot of patients with oral ulcers on high doses of everolimus, and reducing the dose would actually help, heal the ulcer, And corticosteroids, I think you're familiar with the side effects. So finally, it's the last part, common post-transplant complications. So I've divided it into surgical and medical. Surgical complications, you can divide it into early and delayed. The early ones which we fear most will be acute graft thrombosis. So this graft thrombosis can be surgically related, or it's something related to the immunological aspect. So if it's surgically related, it could be because the vessel went into vasospasm, or there's a stenosis there which caused it to thrombose. So that's a nightmare. And in terms of immunology, there's hyperacute or acute antibody-mediated rejection, which has caused this thrombosis to happen. So this can happen in ABO-incompatible transplants. There's also wound breakdown, wound dehiscence, wound infection, bleeding, and urine leak. Urine leak is very common in those on diseased donor list, because I mentioned earlier that their bladder has shrunk so much that there are a lot of issues, when you anastomose the ureter to the bladder, they tend to leak. And delayed issues would be lymphocytes, urinoma, encrusted stents, and infections. So what are the medical complications? Delayed graft function. What is delayed graft function? There are a lot of definitions, but the standard definition used is the requirement for hemodialysis or peritoneal dialysis less than a week into transplantation. So if you perform any form of dialysis in 7 days of transplantation, then that's defined as delayed graft function. Then there are hyperacute, acute, and chronic rejections. There are infections. There are recurrence of primary diseases, metabolic complications, and malignancies. What's most common would be a skin cancer. You can also get Kaposi sarcoma, and you can get post-transplant lymphoproliferative disease, PTLD. So what causes delayed graft function? You can actually divide it into the donor aspect. I've mentioned earlier that, the older you are, the poorer your kidney function is, the graft isn't going to do that well. And intraoperatively, if there are issues where you bleed a lot, where they're manipulating the kidney too much, or the time taken for you to implant the kidney is way too long, 16, 17, 18 hours, you'd expect the kidney to not work that well. So how do you diagnose rejection? One of the complications most feared by us would be rejection. So the gold standard at this point of time is still a kidney biopsy. So we would definitely do a kidney biopsy if there's no urine, if the urine has reduced, if the creatinine isn't great. So there are a lot of kidney biopsies which we do immediately post-transplant. The non-invasive biomarkers would be your donor-specific antibodies or non-HLA antibodies, and the new kid on the block, not so new, but donor-derived cell-free DNA, which demonstrates the risk of the probability of it being a rejection without performing a kidney biopsy. So how do you define rejection? Is based on this Banff classification, which was originally started in Banff, Canada in 1991. And subsequently, as you have seen, it has progressed. And this is an example of how it's classified. So earlier in 1991, when they came up, they had 6 criteria. So the latest Banff classification, which was published in 2019, has only got 5 criteria. They have removed chronic allograft nephropathy and replaced it with BK viremia, and there's no number 6. Then there's infection. So this is called Rubin's graph. So it gives you a rough idea of what to expect, what form of infection to expect, how many days post-transplant. So it gives you a rough idea of how to treat the patient. In view of not having enough time, I'll just, leave this for you to read it later on. So that was the future. Is it xenotransplantation? I'm sure some of you have heard of kidneys taken from a pig, and then transplanted into a human being. So this was done last year, where the pigs had 10 of their genes altered. They've removed certain form of genes which is pro-immunogenic, which can cause some form of infection, and they identified a brain dead recipient. They removed both the kidneys, bilateral nephrectomy. They implanted the pig's kidney. They gave immunosuppressants, actually quite potent immunosuppressants, and they observed if there was any urine. Actually, both the kidneys produced urine. However, this was terminated at day 3 because that was the total duration given by the ethics committee to terminate at day 3. I think it's pretty soon. 3 days sometimes with delayed graft function, it might take weeks, and to define primary graft failure is actually 3 months. So, who knows? It could have worked. So this is just a illustration which showed that the implantation, they had urine, but whether or not it could have been successful, it was too soon to say, as it was terminated in 74 hours. But what they noticed was there was no hyperacute rejection. They did biopsies, there was no hyperacute rejection, and there was no vascular rejection. So this is something positive, that we could actually utilize this in the future. So I've come to the end of my talk. In summary, kidney transplant is the best modality. Please think of kidney transplant. Please tell everyone about kidney transplant. And there are a lot of patients on dialysis now. So, with the lack of donors, it's really hard to accommodate transplantation. So we need to know immunology to give the best immunosuppressants to prolong graft survival. There are certain surgical and medical complications. And what I didn't highlight earlier is the importance of a multidisciplinary team. You need your urological surgeons, you need your neurosurgeons, you need your transplant coordinators, you need your anesthetists, to provide ICU backup to assess them. You need your radiology colleagues, because immediately after transplant, you'd call your radiology colleague to scan the graft, all perfusion good, you're really happy. And you'd have so many scans performed after transplant. So, they are your best friends. You need your pharmacists for medications, you need your dietitians, and what is the future of xenotransplant? So I'll end up with a few pictures. So this is where I work, Hospital Selayang. This is my unit, my transplant unit. This is my nephrology team, in Selayang. This is my old mentor, Dr. Wong. He has retired now. So he took us, in transplant posting. These are our surgeons, we're in OT. That's our beautiful kidney. So thank you so much. I think, ran a bit over time. Thank you.
Okay, we thank Dr. Dewa Mera for her comprehensive talk. We only left about 2 minutes for question and answer.
Sorry.
Yeah, is there any questions from the participants? So maybe I will start with the ball rolling by asking the first question, Dr. Dewa.
Yes.
So for a young female post-renal transplant patient, when she will be allowed for pregnancy?
Okay, there are a few guidelines. If you look at the American guideline, they say if you have a stable kidney function with no recent rejection, if your creatinine is less than 1 to 3, there is no significant proteinuria, your BP is well controlled, you're allowed to get pregnant. But in Malaysia, we prefer it to be 2 years. So if they're 2 years, I'll let them get pregnant, provided no recent rejection, creatinine is less than 123, and no proteinuria, significant proteinuria.
Yeah, another thing to add is you remember need to change to your MMF, the mycophenolate, to azathioprine at least 3 months before. Yeah.
Yes, correct.
So yeah, so far I didn't see any questions from the participants. Kelvin, your side, any questions?
Wait, there's one question from the floor. Here, a few European countries use the opt-out option for organ donation instead of opt-in. This is perhaps why their transplant rate is high. Is Malaysia moving towards this?
I don't think we will move, to that. The Spanish group really did a very good job. The reason their transplantation rates went up so high is because they established the hop-out system. So their number of transplantation just went up. Unfortunately, I don't think Malaysia will move in that direction because it's very cultural, based so far.
Yeah, is there any other question from the participants? Maybe I ask the last questions, Dr. Deva. So if a renal transplant patient was admitted for an infection, what we should do with the immunosuppression drugs? I assume the MMF, the tacrolimus, and steroid. What do you do?
Correct. Okay, in general, if they just come with an infection, but they are not in shock, which means they are stable, their BP is stable, they are not in compensated shock, I would still continue the tacrolimus and mycophenolate, and also the prednisolone. I wouldn't stop it. You would add on your antibiotics. But if the patient comes in with shock, I would then stop their tacrolimus and MMF and convert it to hydrocort. And as soon as the patient is off inotrope, I would straight away start them back on MMF and tacrolimus. Of course, if the white cell is really high, tacrolimus first, and then monitor and initiate back on MMF.
I think I mean each one have their own practice. For me, I am a bit cautious. So if someone admitted for infection, I will stop the MMF first. So if they have a severe infection, I will consider off both the MMF and tacrolimus from the start of if severe infection. So another thing is you need to escalate your steroid dose, maybe 2 or 3 times the previous dose. Yeah.
Yeah, one has to know that when you have infection, it also stimulates your antibodies. So they are prone to rejection as well. So yeah, so be a bit cautious. Yeah.
So is there any other questions? If no, I think I pass back the host to Kelvin.
Yep. I guess it's time's up and we'll end our session today. Thanks again to Dr. Deva for the wonderful talk. And thanks, Dr. Teng, for chairing the session. And thanks, everyone, for participating today. We'll meet you again next week. Goodbye.
Thank you. Bye.